I would like to introduce three people. I think is this the first time we've had three, maybe? I don't know, I can't remember. I think we have three presenting speakers. We've had two before, I don't think we've had three. So we've got Dan Steward, Gregor Russell, and Eloise Ryde, and they are coming to tell us about both the little bit around the whole SMI project, which is the research project, but also the Primrose project, which is a very close relation of that. So I'm going to start by just doing a little introduction of all of them, and then we can move over to the presentation. So Eloise is a researcher at the Improvement Academy as part of the ARC in Yorkshire and Humber. She has a background in mental health trials and transitioned into implementation science 2 years ago. Right up my street. Her experience spans do you know what? I think it's too hot. Her experience spans a variety of mental health studies, including large-scale randomized control trials examining loneliness, depression, and multiple long-term conditions. Recently, she's focused on implementing interventions to promote well-being among secondary school-age children and embedding evidence-based guidelines supporting care for people with complex mental health conditions who are at risk of or already experiencing poor heart health. And she leads the coordination of the impact team at the ARC in Yorkshire and Humber. Gosh, Eloise, that's a massive portfolio. We should probably have a chat sometime, because that actually sounds like there's a lot of crossover with the work that I'm currently doing and what you're interested in. And then we move on to Dan. So Dan and I have communicated a bit over email now for a little while, but I think this is the first time we've properly met. So again, we should probably get together as well. Unlike Gregor, who I thought I knew but don't, but that's a different story for another day. But Dan is an early career researcher based at Newcastle University, and he has a background in population health, diabetes research, and more recently, mental health research. He has worked across a variety of mental health projects, most notably the whole SMI project, which was led by Emily Oliver. And he's been looking at the intersections between mental and physical health support and the transition from inpatient back to community settings. And he also has extensive experience in public and patient engagement. Now, Gregor, who's just disappeared from view there. Oh, back. That was a quick disappearance. I was convinced I'd already met him, but I haven't. So there you go. That was in another life, perhaps in a dream world. So Gregor is a consultant psychiatrist and the R&D director at Bradford District Care Trust. He was the local principal investigator for the Primrose version done at University College London, leading its implementation in Bradford, along with colleagues in primary care and the local mental health services. And one of the things that I think attracted me to ask the people from the Primrose Project to initially come and do this piece of research is because although this is research and we do focus very much on applied work, this research was done in an applied setting. And personally, I think we need more of this so we can actually learn from the research and work out how we can apply it. Because so often there's just a disconnect between the research environment and the realities of clinical daily life. And I think this project to me speaks a lot to that. So I'm going to hand over to you guys and you can get going. Let's just start sharing and make sure everyone can see. There we go. It seems to be coming. Perfect. So as the speakers start, if you've got any questions, pop them in the chat. And when we get to the end, we'll come to all your questions at the end. We usually have a very compressed amount of time at the end. So if there's questions that are like related, we'll try and stack them all together. So over to you guys, off you go.
Great. I hope everyone can hear me. So hello from myself, Gregor and Dan. Thank you for taking the time to listen to us on this incredibly hot day. Next slide, please, Dan. So myself, Gregor and Dan are going to talk through the learning and findings about the implementation process and adaptation of Primrose, which is a pathway that aims to target improvements in cardiovascular disease risk in people living with serious mental illness. Just a quick note, based on our work and discussions with the Primrose patient involvement members, I'm going to be using the term complex mental health conditions rather than serious mental illness to describe the population of our research as we go forward. So Gregor, who's actually a clinician and researcher, will talk behind the why behind the research and his experiences of implementing Primrose, particularly within Bradford. And then we'll go on to talk a little bit about our implementation research findings, thinking about what these mean and how they might be better prepared for implementation in future. And then Dan will finish up our presentation by talking about our sister project, Whole SMI. So over to Gregor.
Hi, everyone. So as you've heard, I'm Gregor Russell. I'm a consultant psychiatrist and based up in Bradford, and this is Bradford. So it's Bradford and the district because we've got the metropolitan area up in the top left corner there. One of the largest cities in Britain, a very diverse and city with lots of challenges, but a great place to work. But we've also got many other parts to our catchment area. We've got the moors of West Yorkshire, we've got Saltaire and its World Heritage Site, and we stretch right up into the Yorkshire Dales. So next slide. Thank you. So a bit more about Bradford. As I say, one of the largest cities in the UK, with one of the youngest cities in the UK, and a very diverse city, but also a city with lots of health challenges. And if you're going to come and do research, you want to have a population where the conditions represented. Bradford certainly is someplace where people have got possibly, sadly, more than their fair share of health challenges. So there's certainly plenty of research can be done in Bradford, and I'm glad to bring the project here because it should be added, and I'll speak a bit more about this later. Primrose is a long-standing research programme, and I've joined it very late in the day. So this was at the point of implementation research. Primrose emerged out of London, but they were looking for other sites in the UK to implement and to get more applicability across various settings. So I was contacted by a colleague at York University who wondered if I might be interested in being involved, and I said yes. And 5 years later, here I am still involved. So saying yes gets you to take lots of interesting pathways. So next slide, please. I'm sure you'll know all the background here, so I'm not going to dwell upon it. What we know is people with severe mental illness, complex mental health presentations die far earlier than the general population. And sadly, this is largely being driven by preventable illnesses. These are modifiable factors, and unfortunately, people with SMI do not get them modified to the same extent and have not seen the health gains that other parts of the population have done. So that's something that we've been working for some years now to try and address and find a way to effectively change outcomes for this group. Next slide, please. A key part of that, well, could have been the annual physical health checks. So it's mandated that everyone on the SMI registers, while they existed, should have an annual health check, which should have these components. And they will flag up, if done, the unmet need in cardiovascular morbidity, which hopefully would then drive action to change people's lifestyle approach, maybe change people's treatment in order to reduce the risk. And there was incentivization for primary care to complete these. But unfortunately, as you'll see in the next slide, it hasn't had the impact one might have hoped. These are happening, nearly 2/3 of people are receiving the full health check with all six components. But in the time that the health checks have been there, the mortality gap has not reduced. In fact, if anything, it has widened. So it's clear that just doing an annual physical health check is not enough. It does not change the outcomes. So you're going to have to do something in addition to that. Next slide, please. And that's where Primrose comes in. So I can't take any of the credit for this. Primrose has been around long before I got involved. David Osborne at UCL is the chief investigator and has seen the programme through many phases, from the initial pilots, developing an RCT, modifying that with an adapted version of it, and then another adaptation to produce the UCLP version of Primrose, which is the point at which I arrived. So you can see these are some of the publications that have come out. And is there some? If people can put their microphones off if you're not speaking just now, because I can hear interference. So you can see in the top left-hand corner there is an RCT which proved that this can be effective and is cost-effective. But as was alluded to, taking stuff from the research world into clinical practice is a tricky journey, and that's where the implementation project that I was involved in came in. So next slide, please. Here's a bit about Primrose. What does it look like? Well, it's adapting and extending the annual physical health checks. So people come for their health check, but instead of just monitoring them and then sending them away, nothing being done, you do more. You identify, well, first of all, you identify who's in the greatest need. So there's a stratification tool, which could run on EMIS and System 1, which would set the order. You'd invite people coming in so that the people that were potentially most at need would get seen first. And then once you've done the check, you review the results and you co-create a care plan from that. And you work with the person to identify behaviours that they may be willing to address, and you support them to access those resources that might help them address those behaviours. And there's also a clinical review at which their overall health would be looked at. And ideally, if a statin was indicated, they would be got onto that, because that was seen as one of the biggest modifiable factors that people were missing out on. And there was also aspects of Primrose where people that didn't attend, people that didn't respond to the invitations, there'd been assertive outreach component to that. There would be mechanisms in place to engage people and bring them back into the process. So getting checks in the order where they'll do the most benefit, engaging people in discussions about how they might address their behaviour and support to change that behaviour in ways that will hopefully change their cardiovascular risk, getting their medication reviewed to get them onto the optimum primary prevention, and then outreach to bring people who were disengaged back into the process. So you put all that together and you've got Primrose. Next slide, please. So Bradford, there we go. We've got a lot of people on the SMI registers across Bradford, and most of them get a health check, maybe slightly above the national average there. Maybe this is because it was seen as one of our ICB's 10 big ambitions. So the ICB had to decide the 10 things it was going to focus on the most, and improving the health for people with SMI was one of those 10. So there was hopefully a willingness and a readiness within the system to adopt measures that would help realise that. Did that happen? Well, we'll see. Next slide, please. What was the status quo before we put Primrose in place? Well, a fragmented system. People went to their GP surgeries to get health checks. Many of this group were also open to the secondary care provider, BDCT, and they got a health check there as well. So people might get 2 health checks, or they might miss a health check. And if it was done in primary care, we didn't know about it, and vice versa. There was no ownership, really, no accountability, and no sharing of information. So there was certainly the system was persuaded this was a good thing and we should try it. And we had a run-in of about a year while we got partners on board and did some training. And then from April 23, one of the primary care networks in the centre of Bradford introduced Primrose as the way that health checks will be delivered. So it was that's now going forward. That's what these 4 practices would do. Next slide, please. In fact, could you skip to the next slide after that? Because I think that maybe shows what happens better. So I dug out some data on the completion of health checks over the course of Primrose. So the first vertical line is the point we decided we were going to do it, and then there's a year of running, and then the second vertical line is when we actually went live. The lines running across the way, the orange one is the average completion of health checks across the Bradford Place as a whole. The blue line is the primary care network that we were working with. And you can see actually it was lagging the average for the district before Primrose. And then at the point we decided we'd do it, it seemed to be, I don't know what went on there. There seemed to be a kind of, the focus, my interpretation of that is putting the focus of this on the organisation. People started looking at it, and we saw an uptick in the completion of health checks before we even started Primrose. And then throughout the running of Primrose, having been behind the district average, the PCN was around 5 to 7% ahead of the district average. Kind of closes in about towards the end, as there has been an improvement in the average completion overall across all practices in the Bradford area. But you can see that there seemed to be an effective Primrose. It got people focusing on this, and at least the health checks were happening. If you go back one now, please. So the other things I was able to pull out of some routinely collected data were that we did see an increase in statin prescribing, and we did see people referred for the coached behaviour change. So smallish numbers, but the qualitative feedback from that was that the people that engaged did seem to take it seriously and make significant changes. It wasn't possible to pull any data to back that up, though, which was a bit disappointing, but it kind of showed how challenging working with System 1 is to actually get data back out of it that can support service initiatives. So if you skip forward 2 now, because we've done the graph. So what went well? Well, I was really struck by how much enthusiasm there was from the staff in the primary care network to do this. You know, GP surgeries are under a lot of pressure. There's always calls for them to do more. And I was a bit nervous I might meet with a, oh no, you know, another thing we've got to do. But in fact, that really wasn't the case. There was a sense that this was an unfairness, that this group of people were not getting the care they needed, and that something should be done, and they were happy to be involved in supporting that. The training went very well. We had support from colleagues in the voluntary sector for this. We required in-person attendance, but we still got people coming, and the people that came to training thought it was really useful. We identified people to deliver the behaviour change coached intervention, and as I say, the feedback from the staff doing that, it tended to be social prescribers at the GP surgeries, was that it was valued by the people doing it, and people seemed to take it on board and make changes. You know, one of the key points is getting the statin prescribing increased, and we were able to show that more people ended up in statins, and that was, I felt that was a real underestimate of the potential, because one of the things that will come out in the next slide is that it wasn't universally rolled out across all sites, and the increase in statin prescribing reflected really the practice probably at one of the 4 GP surgeries, and yet we still got a large uptick in it. And it left me thinking, gosh, if we'd got this equally applied throughout the whole PCN, we'd have seen an even more dramatic impact of it. And I think the working between the primary care and secondary care and the voluntary sector was pretty good really throughout that. There was really excellent kind of collaboration across the duration of the project. So next slide, please. It didn't all go well. There was a stratification tool I mentioned. That didn't land well with the GP surgeries. They felt it was burdensome, and it disrupted their own processes for recalling people. We were meant to have an outreach worker. If you recall, part of Primrose is you go and find people if they're not coming to you. And we never really got that properly in place. It's too long a story to tell here, but suffice it to say, navigating NHS HR processes is not straightforward. The communication issues, one of the reasons that we got the go ahead of this, the kind of knitting together primary care and secondary care, we still never solved that, and it's still not solved yet. Getting, even though we all use System 1, we don't task and we don't have sharing in and sharing out set up. So that was never properly resolved. And as I've commented already, there was 4 surgeries across the primary care network. My understanding of what a PCN was evolved over the course of this. I thought it was kind of basically one organisation with 4 sites, and it's 4 organisations with a very loose connective tissue between them. So not all 4 were equally engaged, and it was quite hard to get that sort of awareness of it at a high level across all the areas. I've commented on the difficulties of getting data out of System 1, and it would be fair to say that as the months and years went by, there was a lot of enthusiasm at the beginning, but then other exciting initiatives come along and priorities move on a bit, and there was a degree of implementation fatigue. So I think I got the feeling there was an optimum time to roll out, which we kind of missed the boat on. I think I've got, what have I got, one more slide, or is that? No, I think that's me done for now. So I'll hand over to Elle.
Thanks. So this next slide really is just picking up on what Gregor's just talked about and his experiences within Bradford, but this is a bit about the actual research findings. So we did some research, like Gregor, I joined a bit later and just in the implementation phase of Primrose. So from 2022 to 25, we kind of researched the implementation of this latest iteration of Primrose. And this was done in 24 general practices which were connected to secondary care and voluntary teams across 4 areas. So that was actually in 3 London boroughs and then also in Bradford, which Gregor's just talked about. So we explored how the kind of cross-sector teams work together to set up and deliver Primrose, and we really aimed to understand what helped them and what got in the way of it when implementing in different local contexts. And then we examined kind of potential for sustainability, spread and scale up of Primrose. So just some examples of data, because I'm not going to go into all of the research methods, but we collected approximately 59 interviews, 240 hours of meeting attendance and ethnography work, and kind of 4 focus groups were conducted as well. So we used some complementary analytical approaches. Again, I'm not going to go into it, but we really drawed on kind of established implementation frameworks and theories, such as kind of normalization process theory. So throughout the project, we also hosted a load of patient and public involvement meetings. So we had 32 meetings working with multiple involvement groups, and that included service users, carers, health professionals, and then also people from the local authority and ICBs. And we really used those groups to help shape the research, interpret our findings, and kind of co-develop outputs. Next slide, please, Dan. So really in brief, really speaks to what Gregor's already talked about, but this is kind of the learning from all of the sites. We found the iterative implementation efforts and pockets of good practice were everywhere. Success was really driven by that kind of strong local leadership that Gregor's talked about, and reflective learning, and good collaboration across primary care, secondary care and voluntary partners to kind of help teams adapt Primrose to their local needs and resources and to support the patient engagement. But there were challenges, again, as Gregor's mentioned. The evidence-based care was really slow to embed. So the mental and physical health services remain really quite fragmented, and the wider NHS capacity pressures really limited our delivery. But priority was pulled out to the health checks, which are incentivised under QOF, the Quality and Outcomes Framework. So rather than a follow-up prevention and intervention activity. So as we continued our research into 2025, while Primrose was viewed as really valuable and accessible, the system instability, the workforce kind of turnover, shifting policies and limited resources really frequently disrupted our progress. As Gregor mentioned, we kind of had a great bit at the beginning and it tapered off towards the end. So our spread efforts, so they tended to really rely on individual champions, and scale up was really held back by kind of unclear pathways and the tension between rapid expansion and local adaptation needs. But despite the barriers, participants were really cautiously optimistic. They saw a really strong fit between Primrose and current priorities around prevention and population health, and felt that the integrated neighbourhood teams, as they mature, Primrose is really well placed to kind of support more joined up care for people with complex mental health conditions. Next, please, slide, please, Dan. So trying to make it really practical for this group. So we've pulled out some really kind of key recommendations. I'm just going to go through a few examples, but actually on the UCL website, you can access all of our materials, including policy briefs and papers, which go through a lot of these. So for policymakers, our key recommendations were to prepare the system to support evidence-based preventative approaches like Primrose. So this may include things like de-implementation, but also being more selective with priorities and keeping a focus on those priorities for longer. We also suggest improving integration across sectors, including better connecting digital records. Gregor's already touched on System 1. And then also investing in joint mental and physical health training. That came out of some of our qualitative research. So for the implementation and delivery teams, the people on the ground actually delivering this, we suggest following the Primrose roadmap, which is on the screen, but you can access it online as well, for increased chances of sustainable implementation. Adapting delivery to your local context and area is quite important. So adapting it to your resources and your available staff. Again, there's information on how to do that. But really we want to hone down on this preventative model is just tweaking existing care to move it closer to evidence-based best practice rather than it being something totally radically new. And really we encourage working towards a self-learning system, so giving people the space to provide ongoing training, reflection, and some clear leadership. And finally, we have some recommendations for patients and carers themselves. This came from our patient involvement group, who felt that the onus shouldn't just be on the delivery team and those in the wider system. It should be on patients themselves. So they suggested that patients actually ask for joined up care themselves, share what matters most to them, and also get involved in shaping services as services change through the policies. Next slide, please, Dan. So just a quick 2 slides from me. So first, where to find information and practical support for implementing Primrose. So there's a QR code on the screen that'll take you to the partners website. So we've worked with Health Innovation Network, UCL partners, and people with lived experience to create a really comprehensive package of supporting materials. These are all freely available online through the QR code, like I mentioned. But the package includes itself. So there's the Primrose Care Pathway. There's delivery manuals, an implementation guide. There's NHS England recommended training, which also comes with video playlists, e-learning modules, and in-person lesson plans. And these are all freely available, so please do use them. So next slide, please, Dan. And just wanted to bring us back to kind of the bigger picture and end where Primrose might sit going forward. We know that the system's really turbulent and has been recently in the last year or two and is going forward. But our research really suggests that this turbulence can really create the conditions for some meaningful change. So Primrose really aligns well with current professional standards, including NICE guidelines and NHS England priorities. But it also sits really well in wider strategic goals. So that kind of NHS shift from sickness to prevention and hospital to community, and the national aims to reduce health inequalities such as Core 20+5. So ongoing structural reforms, such as the development of integrated care systems and neighbourhood teams, are creating better foundations for joined up care and places like Primrose. But importantly, I think we need to bring it back to Primrose fits really well with the expectations of service users. We've done an awful lot of work with service users and carers, and they've really helped shape from the start. But Primrose really aligns well with recent evidence summaries from the House of Commons report on community mental health services as well. So together, kind of all of these drivers mean that Primrose and our implementation research was not only timely, but I think it's really positioned us well to support better preventative and more connected care for people with complex mental health conditions going forward. So I'm just going to hand you back over to Gregor, who's going to just talk about the conclusions of Primrose in Bradford, and then he'll move on to Dan.
Yeah, thanks, El. So just to kind of round it off, I think my excitement about Primrose as a clinician was that it seemed to fit a clear need and be a way to address the thing that we've known about for a generation now, which is these poor outcomes for people with SMI. And it was a way of kind of making good on that mantra about don't just screen, intervene. This was the way you could intervene, and it had a realistic expectation you to change people's outcomes. And I think that's why it was such an easy sell, that everyone you told about it said, of course we should be doing this. And they were all really happy to get involved. And I felt we sort of saw the glimmerings of what this could do if we'd actually managed to implement it to the maximum possible way it should have been implemented. You could just see how there was these signals there that this was having an impact. And for example, the statin prescribing. And I think that, my frustration was, new to implementation, it's kind of out my area. I'm actually an old age psychiatrist, not a general adult psychiatrist, but I could see that there was an optimum point that we had a system-wide meeting, and there was a kind of go, no go decision. Do we roll this out across GP practices across the district? And we didn't have the kind of the data at that point to persuade people. And that's why in the end, I feel it has kind of fizzled out. The host PCN moved on really to other things, and we didn't get that kind of broader spread to other areas. So I do wonder, that so a sense of a missed opportunity there, and a sense of how it could be done. That if you're going to do it in that bottom-up way, that was the kind of the way that you might get it done, but that getting the data out of System 1 to demonstrate it was just in the end too challenging. And unless you've got the resource to do that, then you're not going to get people to shift without showing them the impact. So I think there are limits to the bottom-up approach. I think kind of policymakers could have a role here. I think this is such a clearly the right thing to do that I would hope that, for example, when the modern service frameworks come out, it would be nice to see that Primrose might get in there, and there's certainly a possibility, because I think it does need a signal to people making decisions that this is something that, or something very like it, should be done, and that they need to find ways to support it happening. So I think that's the kind of way you need the kind of local champions and the interest, but you also need the signal that somehow the system's got to find a way to make this happen so that people are supported with data, with kind of tech project support when it's needed. And I think with that, this could succeed, and I hope it does.
Brilliant. Well, thank you very much, Elle, and thank you, Gregor. So I'm going to talk to you a little bit now about some of our efforts that we've done in the sort of Northeast to address this sort of need. So for the whole SMI sister project, which is a sister project to the Primrose pathway, we wanted to take that pathway and contextually adapt it to meet the regional service and patient needs. For added context, health inequalities in the Northeast and North Cumbria have been worsening over recent years. And we also wanted to address the need for holistic and more integrated support for people living with severe mental ill health. And just to say, I'm going to use the term, I know Elle used a different term based on their community engagement. I'm going to use the term severe mental ill health because that's what our community advisory group preferred us to use up in the Northeast, just as a way of honouring them. So yeah, basically that integrated care of looking at mental health, physical health, and wider social determinants of health. We all know that a lot of physical health services and mental health services all operate in silo, and there can be communication issues between the two different sides. Also, in acknowledging a constant sort of resource challenge, we also wanted to make sure that we were utilising existing resources in the best way possible. So this was an implementation science project, so we also wanted to be able to describe the implementation processes and mechanisms within the local healthcare systems as well. So firstly, there was significant buy-in from all stakeholders. So that's from sort of healthcare professionals who are our participants and who were helping us with the project, and also to our participants who were experts with lived experience of severe mental ill health, and our community advisory group also with lived experience. So really to sort of develop new ways of working in a more integrated way and enhancing the physical health check as well, but also regular appointments in general as well. So we had a lovely sort of, there's a few different quotes here from all sorts of different participants. So there's healthcare professional quotes in there as well with lived experience. And one that we had was a really nice one, that the physical health check should be the floor and not the ceiling. So again, following on from what Gregor suggested, really having that targeted follow-up from the physical health check, making that sort of more meaningful and what next kind of approach. We did find that there was very sort of, so just to say, firstly, our project mapped the current provision across the region. We identified service and service user needs, and we also looked for opportunities where Primrose or components of Primrose could enhance that existing mental health service offer for different areas. So yeah, we found that there was very, very variable engagement in terms of getting people that were on the SMI register to engage in the annual health check and the physical health check. Some places were doing it a lot better than others, and we found a few challenges that certain areas were facing that maybe others weren't. So one of the big things about the Northeast and North Cumbria is that there's significant variation in geographic landscape. That's particularly important when we consider the resource and provision and levels of engagement can be really challenging, and particularly in coastal, rural and remote areas. So taking those sort of those sort of findings from that first phase, looking at those needs, those gaps in provision, where we might be able to enhance that. We then engaged with 5 local integrated care boards in the region, and implementation efforts progressed in very different ways in each. Ultimately, though, we were not able to implement Primrose in the North East and North Cumbria, whilst there was a strong appetite to implement something that was evidence-based and NHS England endorsed. Contextual factors at that time heavily impacted the progress and efforts that were made. So at that time, I'm sure everybody may remember, this was a couple of years ago, healthcare across the whole nation was still recovering from the fallout and burnout of COVID-19. Of particular note at that time that we were engaging is that the ICBs were going through significant restructuring at the time. So the people that we were engaging with were leaving positions as we were in the middle of sort of trying to implement things. There was also a lot of confusion over what the implementation processes were, what the responsibility to have sign-off, where that sort of landed and fell. We experienced a bit of gatekeeping, so there was, if one particular person in ICB that we were engaging with didn't want to engage with us, it was very hard then to know who in the NHS and in the ICB to be able to speak to after that. There was staffing and resource issues, particularly in the workforce, and especially on the border as well, which I hadn't appreciated. Scotland were able to offer slightly more attractive packages to healthcare professionals, which impacted how recruitment for positions was in the North East and North Cumbria. There was training concerns, whether that was who was responsible for the delivery of training and at what cost. And as with Primrose and what Gregor's mentioned, there was implementation fatigue, priorities moving on. We also experienced a variable understanding of what Primrose was and what it was able to offer, with a lot of people believing that they were already doing something that would meet those objectives. So whilst we were able to describe the different implementation processes to a certain extent, had a lot of data on the challenges of implementation, we then started to look at what we can do in that space when we're not able to necessarily implement something. So we started looking at what other areas were doing, and how we could capture some of that best practice, and look at how we can encourage and recommend ways that services leaders and service deliverers can make realistic and sustainable service adaptations to address those integrated and holistic needs. So we did this through a lot of ethnographic site visits, and working with some community organisations that fed into the sort of mental health offer of a particular ICB that was really engaged with us. And we were really lucky to carry out something called ripple effects mapping workshops with a couple of our community organisations that fed into that service. And this diagram on the screen here is one of the diagrams that we made with one of the sites. So we really got to go in there, sit down with key service delivery staff and managers and team leaders to really explore some of the key service impacts that aren't necessarily captured in regular forms of reporting. So this was a very valued process, especially as it can take a lot of time for certain outcome measures to really present themselves. And if you've got this can be quite a problem when you've got really sort of short and fixed term piloting. So it was really good to be able to create this sort of visual output, co-producer, I should add, with organisations that show sort of different ripples of different impacts and how that ripples throughout the service and how they've been able to adapt it. Obviously, I appreciate this is really, really little text, so please don't worry about trying to read that. I just wanted to be able to sort of show you what some of the sort of system-y type work we were doing with them. So we did this with 3 different community organisations that allowed us to be able that allowed us to be able to sort of go in and speak to them. And it was really good to be able to sort of see that they were able to prototype their approaches. So that means that they had been commissioned for an extended period of time, a bit longer than a normal pilot would be. And they also had the flexibility to be able to adapt that service and to local needs. And to add as well, ever-changing sort of service and local needs as well. And then we were able to sort of use our findings from the implementation efforts and our ethnographic site visits and our ripple effect mapping workshop data to be able to develop key recommendations and guidance for service leaders and service deliverers that very much sort of complements what Primrose has been developing as well. So again, sort of coming up with sort of recommendations for where we think things should start happening, and especially sort of in primary and secondary care settings, but also at strategic and policy level settings. Some of our suggestions and recommendations are for clear leadership roles and cross-boundary partnerships, having those flexible referral pathways, so allowing for things like self-referrals, community referrals, targeted follow-on appointments, outreach engagement as well, but also re-engagement opportunities. Especially for people that with fluctuating mental health needs. Looking at a language shift as well, so moving away from a more medicalized language to something that's a little bit more relevant to the people, to service users, and something that they can connect with. Targeting those as well that aren't on SMI registers. We've actually published a commentary on sort of the slightly problematic SMI registers and that sort of labelling and stigma that goes with those sort of diagnostic labels sometimes. But we also know that the register omitted people that weren't registered with GPs, that had never engaged with healthcare systems, and yeah, that had lots of different diagnoses that were different presentations of things that fell outside of sort of diagnoses as well. So yeah, and then moving beyond reactive models, so really thinking about how we can offer something that's a lot more proactive and in line with with policy as well. But something that was able to build trust and relationships as well. And when I say sort of facilitating trust and relationships, I mean that in two ways. So the first way is the relationship between commissioners and services that feed into that service offer, really allowing that relationship to blossom, to be able to adapt to the service as they need to, and then that in turn can help facilitate a long-standing relationship between service user and the service as well. Ensuring implementation of national policies at local levels. We see a lot of policies that say certain things, but it can be quite difficult to see how that's been implemented at a local level. Allowing stable long-term funding to creatively commission services. So that, again, that's essential for building that trust between services and ICBs and commissioners, for allow trusted and high quality services that meet people's needs, and technology and data sharing, so across sites for integrated care and improvements in communication as well. So yeah, just really sort of to bring it home a little bit. So having those community-based approaches and peer support approaches, focusing on holistic health support in routine care, creating those spaces for best practice that we've mentioned, but really sort of embedding co-production principles. So actively involving people living with severe mental ill health in shaping and refining services. So we were able to sort of develop a policy brief. So I know I've just sort of whizzed through whole SMI and talked very fast, but the QR code on the screen will take you to the whole SMI policy brief that we developed. This is an image from that brief, and yeah, you're free to use that as you like, but that gives you a lot more detail about what whole SMI was, what it actually did to get the data a bit more, and our service deliverer and service leader recommendations and guidance as well. So you'll be able to see that on that QR code in a little bit more detail. But yeah, really sort of complementing what Primrose have recommended and what their suggestions are for being able to, in areas where we're not able to implement something, still be able to think of ways that we can do something else instead in that sort of way. And we've been working with healthcare professionals. We did a conference earlier in the year where we really, it was more sort of a workshop, I'd say, actually, where we were really asking people to sort of think on an individual level what they can do in their day jobs to be able to make steps in the right direction for this integrated and holistic care, then also think about what we could do at an organizational level, and then what did we need to do at a national level. So really sort of having that sort of wider sort of thinking behind it as well. So just before I finish up, I would be amiss not to mention a project that I'm currently working on called Paths to Prevention. There may be a few people on this call that have heard of this already. I've been emailing a few people that I think might be on the call. So this is really looking at physical activity referrals and pathways that are specifically available to people transitioning back to the community after an inpatient mental health stay. And this QR code on the screen is to invite anybody that has knowledge or experience of either commissioning or delivering in this space to take part in a national survey that helps us to know what's happening in your area, but be able to map the current provision across England, with the idea that for areas that have little to no provision in this space, we'll be able to co-develop a physical activity referral pathway that will fit in that space and be something that will be implementable as well. So yeah, I just want to say thank you to everybody for allowing us the opportunity to speak today. It's been really nice to sort of get the opportunity to share what we've been doing, and I just want to thank as well Gregor and Elle, who are on the call, but also our collaborating colleagues that are listed on the left. That's only a few of them. There's definitely more that are missing, and also all the organisations that have helped us fund our research and work with us as well. So thank you very much. I guess, yeah, do we have any questions?
Sorry, that was me. I was actually staring at your list of collaborators, then realised, oh gosh, that's me. I'm on again. Sorry. So, God, I think I could actually probably spend all week talking to all three of you, because there's so much overlap in all of the different things that you've all discussed with what my own research interests are. So if anyone's got any questions, can you please let us know, because we can ask those right now. And there's about 20 people on the call, so hopefully someone will have some. What I wanted to say, which I think is what you alluded to, which is probably the output of your workshop, Dan, is, and especially I mean Greg can probably come into this as well, is a lot of the people who are on this call now are potentially, they might see themselves in a low position of responsibility and power in the whole system. And we know this is a system problem, and it's not a problem that one discipline can fix. But equally, if you're a clinician working on the ground, what could they do? What was the outputs of your workshop? What did people think could be a possibility for them to be able to do and follow up in their own respective services? And I guess that would vary, by discipline as well. I just wondered what your thoughts are on that. And anyone else who has any questions can come forward.
I mean, I can speak to that from a research capacity, and I think this is sort of important and a good reason to engage with researchers, especially in healthcare settings. Having that conference that we did earlier in the year and being able to do those ripple effects marketing workshops, it's really sort of engaging with healthcare professionals in a bit of a different way, and giving them the space and opportunity to reflect on their service, reflect on how it may have adapted over time, where it still needs to go, what are we still missing? Because I think in the hustle and bustle of sort of everyday 9-to-5 life, it can be very difficult to find that space to really reflect and really think a bit more proactively, especially when with limited resources and things like that. It can be very much jumping from one burning building to another just to put out fires and things. So yeah, it can be difficult, I think. This happens in lots of different employment settings as well. You just don't have the space to be able to think about certain things sometimes. So yeah, really creating those opportunities, recreating those best practice sharing opportunities as well, I think really sort of help others be able to see that, oh, okay, maybe there is something that I can do at either like an individual level or an organizational level that can really help enhance in this area.
So I'd like to sort of, I suppose, follow up with that and say we are very interested within the network to be able to find those pockets of good practice. Essentially, the I have done this in my service, even if it is like something really, really small. And we would love it if people could get in touch and let us know what they've got, what they've done, even if it is really small, and what they've done within their own practice, because these service level innovations are happening at various scales across the country, but generally because they're not research like you and I would conduct, Dan, or, you know, then we're not publishing them because they're service level innovations. And I think sometimes someone else can learn from those service level innovations and go, oh, I could do that. That's actually not too difficult. We could do that in our service. And I think we need more of trying to bring that together so people can see what, and we're probably reinventing the wheel a million times over across the country with everyone trying to do the same groundwork. So if we can do some shared learning, I would very much be up for that. So if anyone knows of anything, it doesn't matter how small, perhaps you've just made a list of all the men's sheds in your area or whatever, then that they can be brought together, because that can provide something very useful and very meaningful for services to go, actually, in the grand scheme of things, that isn't a massive piece of work. That is something I can do. And it is, I suppose, if you think of the ripple effects mapping, Dan, it's the start of the ripple, isn't it? That very one, you know, that very small steps, butterfly effect, isn't it? That can grow to a bigger, I suppose, a bigger event, really. And I know there's a lot of work, because I'm heavily involved in a trust in the Midlands called the Midlands Partnership Foundation Trust, MPFT. There's a lot of work going on at MPFT at the moment around physical health in serious mental illness. And I think that there's a lot there that I think we can learn from that. And I have some plans for that. But I am interested to know what's happening across our 4 nations and what people are doing to help improve the lives on the ground. You know, it could be something really small. It could be developing a protocol. It could be, I don't know, like QR code to, I don't know, you know what I mean? It could be anything. Yeah, Dan and Gregor, just jump in. You can't talk.
Just to say, one resource. So there was a QR code there to the whole SMI policy brief. Al had put a few QR codes in there as well for the Primrose materials. But one of the things that we did for the conference that I mentioned earlier in the year is we kind of made a compendium, without calling it a compendium, of some of the best practice. We fully acknowledge it wasn't everything that's going on, but it was just a couple that we had engaged with, that we knew about, that we wanted to be able to tell other people about. So what I'll do is I'll send that to you, Joe and Lauren, if you're happy to send that out, because I don't think we've got that online, but we have got a digital version of it, which I can attach to an email.
Yeah, that would be really helpful. Yeah, we can push it out over the network. Thank you. And you never know, there might be something that we go, that's really interesting. Perhaps we'll have a talk on that. Gregor, go on, you can jump in. We've only got 3 minutes left. So if anyone's got any questions,
I'll be concise. So just the question was about if you're a clinician on this call and you want to be doing it's almost certain that your organization is doing something in this safe space already. There'll be someone in the organization tasked with the brief of how do we improve people's health when they are living with SMI. So you might already be that person, and that's why you're here, or you might know who that person is, or you can find out. Well, you're going to be doing something anyway. Why not do something that's evidence-based, and it comes with a huge package of support and a community of practice of people already doing it. So, you know, the materials are there. Have a look at them. There is there's a flexibility. Primrose isn't it's not a prescription. It's a toolkit, and some bits of it you'll be able to use. Some bits, for example, in Bradford, the stratification just didn't work, and the GPs didn't want to do it. So there'll be bits that'll work and bits won't. Take from what you can, implement what's implementable, and if you're doing it as, you know, doing something, if you throw everything out, you end up doing something different. But if you keep the kind of the core concepts of these are the kind of the things that a Primrose model should have, how can we bring something like that to our area? Then, you know, the evidence says that you should be seeing some improvement, and perhaps more improvement than trying to reinvent the wheel and, you know, coming up with your own system. So you'll be doing this anyway. Here's a way you can do it that was possibly a more effective way.
Perfect, thank you. I'd love to stay and chat more, because I think we could just chat all day, from implementation through to the whole research spectrum and everything else in between. But we have reached 1 o'clock, and I'm actually going to another webinar now. I'm going to another meeting. So I've got about 30 seconds to switch. But thank you so much. I'd just like it if we could all just give them a round of applause. Be old-fashioned like me, show your age, do a real one, or do the virtual hand clap that I can never really master in that. Yeah, but you lot all can. Perhaps you've just got more brain space than I have. But thank you so much. I will follow up with you guys by email, because I know, Dan, we've got something anyway in the pipeline, but I think Gregor, I think although we haven't met, perhaps my premonition that we had met is actually because we should meet. So I will follow up with that with you.
Well,
So
thank you very
perfect.
much,
Thank
guys.
you so
Thank
much,
you.
guys. I really
Thanks,
appreciate
everyone.
it. Thank you.
Bye.